All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. We did get some emails this past week. We always appreciate that. Again, from a provider standpoint, please include your byline, just so that we know who you are and what context to respond to you in, because this is not directed to patients specifically. I'm sure patients listen. I hope they get something out of it. Hopefully, it's useful for all parties involved, but not the intended audience. So put a byline there for us, and we're happy to respond to you when we can. Um, Per usual, Dr. Michael Wasson here with Dr. Sam Bobek for a Thanksgiving edition of the Down Fracture podcast. Sam, you got big Thanksgiving plans? You got a baste a turkey?
No, I'm the whole basting business seems crazy. I smoke my turkey. I just got into smoking it, I don't know, good 8 years ago, maybe
Hmm.
10. It's a great way to cook it. So since it works so well, we just keep it going. This year I'm going to teach my 14-year-old how to smoke a turkey. My 17-year-old in theory has figured that out. I'm in practice concerned that he didn't pick up a lot, but anyway, he'll have to figure it out when he gets older. What do you do for your turkey?
I usually rely on others and I just eat until I'm instructed to do something.
You don't
So
cook?
I have, but not a lot, I'm
Huh.
gonna say. I think the people who know me and care about me know enough to not entrust me with certain things
Oh,
that others are reliant upon, and I think this might be one of those things.
got it. Yeah, we're gonna have different experiences. I'm in charge of all the food on Thanksgiving. It's just always kind of been that way. I grew up kind of doing that. So um I like it. Cooking holiday is fun. So
Yeah.
and it's
Are you
nice
gonna get
because
bait? Are you gonna get basted?
no, no,
No.
no, that stuff.
Are you gonna free baste any turkey?
No, I mean, yeah, it's we just kind of do the family thing, so it's good. We're just I'm really just trying to enjoy time with the family, so I'm looking forward to it.
Nice. Um, how many more jokes do you think I can get out of this whole
I think you hit the
basting thing?
max. I think you're
Yeah.
there. I mean, may have been a few, maybe a minute ago even. But
Huh.
I think today we're going to try out something different in terms of topics.
Okay.
I think the idea is to discuss a paper. Seems crazy,
Yeah,
but it's
before
really the
we
topic.
before we get to that,
Oh,
do
sorry.
do you want to thank our listeners, or do you want me to thank our listeners now that we're a little over a year in, and
Oh,
I
yeah.
think
Thanks, Paul. That's right.
we
That's
hit
right.
a
That's right.
pretty good landmark of over 500 subscribed listeners, which I'd say for us is pretty good.
I agree. Yeah, no, it's great. I mean, you know, um, for me, I'm just thankful of going through this every week, like just showing up and talking with you about it, and then engaging with people as they reach out to us has really been great because it's developing a community of surgeons, and it's easy to be on an island, and just by us publishing something online, like our conversations has kind of helped kind of grow that community a bit, and so. Man, I'm thankful for that because I really appreciate that being part of my life now, versus before. Because there's a community obviously, but meeting with them at meetings and um, your local society meetings or the national meetings, it's just a bit different if there's kind of a consistent, common content. So, anyway,
Well, yeah,
I'm
and I
thankful for
think
that.
me, I would echo your sentiments, and you and I talk about things, and I think it's been on here, but I think the one thing that it helps us realize is that we're all kind of fighting the same battles, right? It's
Yep.
just kind of weird that we're doing it independently. Like I'm trying to negotiate or do something within my medical center in Arizona, and you're going through the same thing in Seattle. And when we talk to Farrell, he's gone through it or is going through it in North Carolina. And then people reach out to us from other areas. It's kind of weird how we're all doing these things independently. And I think we having a shared experience and community, as you're saying, can be beneficial, or at least it kind of makes you go, oh, I'm not alone. This is not unique to me. It's not because I suck, although for you it might be, but like
Yeah,
it's not
that's
just universally that. And so yeah, I'm thankful for that too. And it's nice to just go through this with you. And I learn stuff. I feel like I learn just as much as maybe I teach when we go through these exercises, when people respond or tell us how they do things, or when we have guests on. It's helpful.
Yeah. Yeah. I mean, it's a good reminder to bring it up. Taking a moment for gratitude is great. So, this time of year is a good time for that. So,
Yeah,
um,
I think it's
yeah,
a
thanks,
great
man.
time to be thankful and not just be getting basted all the time.
Gosh,
Too
you
much.
had to go with one
All
more
right,
turkey
fine.
pun thing.
Okay, whatever. All
All right,
right.
what are we doing for a topic today?
So I think we were trying to go through what I guess most of us probably in jaw surgery consider a classic paper, and then it had an update in, I think original we found 96, update with rigid fixation was 2007, the classic hierarchy of stability from the North Carolina group of Prophet, Turvey, Williams, right?
Yeah,
Is
so
that the
the
plan?
stability of orthognathic surgery. So stability as a topic, I think, is a broader topic than what's discussed. All of us as residents, I think we were. Wait, can you say this word anymore? Can you say pint or no? Is that
I
canceled?
mean, I will say this, as I do often, is you are 50% owner of this podcast. And
Oh
so
yeah, we don't kick
you
ourselves up.
you can pretty much say whatever you want.
Well, yeah, I mean, at the time when I trained, that's what it was, when you were asked questions challenging and like without end. One of the questions you would get asked about has to do with the stability of jaw surgery, right? And I feel like it's board material. It's just like red meat for residents to learn the knowledge of orthognathic surgery. And a lot of this stuff is useful to go back to like see where that knowledge is from, right? Like, what was involved in that knowledge. Because initially it's just good to learn, right? The hierarchy of surgical movement. So what we're talking about is doing jaw surgery, what dimensions you're moving things, how likely is it to stay in those locations. And it's based off of a couple of papers that Wasson was saying, North Carolina, it's the University of North Carolina. They had a good database. I think it started in the 70s. They're I forget the name of it. It's like their craniofacial research or dental facial deformity part. That they started with their records in like the mid 70s. And a ton of jaw surgery was happening there, and it still happens there, right? But what they had was a lot of orthodontic and surgical records for a long period of time. And so the paper that most people are asked about is the one that you have pulled up here, which is the one from 2007. It's kind of an interesting journal, by the way. I think I would probably like some backstory on why it's in that journal. But it's a combination of orthodontists and surgeons. So Bill Prophet's a famous orthodontist. If you guys haven't heard about that, you should look up a lot of his info. Same thing with Turvey. Turvey's a famous surgeon. Published a lot on these sort of things, and Phillips kind of tied that all that information together. And so this one, which is the 2007, had to do with the update of rigid fixation because over the timeline of the database, starting in the 70s and continues on to this paper, is rigid fixation because originally they used wires for this sort of thing, but now they use plates and screws. And so, were you asked these questions when you were a resident,
Oh yeah.
Mike?
Yeah, I mean, I think this is kind of every few years, this paper was like mandatory to come up in all your literature reviews so that you get it at least once or twice throughout your training. And yeah, it was a frequent thing that was asked on, like, hey, if you're planning this, how stable do you expect that to be, or what movements would you want to account relapse for more relapse for? And I can definitely remember it in some of the intricacies of treatment planning at times was a frequent question I always had was if we're doing bimaxillary surgery, like let's say there's a large class three, and the patient's both maxillary hypoplastic and mandibular prognathic. And the question I always asked the experienced surgeons was, well, how do you determine how much you move in the maxilla versus the mandible? Because as we've said on this podcast numerous times, my training, we did not do a lot of cephalometric tracings and analysis. And so trying to, as a resident, grasp the concepts of that decision making was a frequent question of mine and other residents. And some of that's the one time that I can remember it coming up multiple times of, well, part of my decision making is the stability of the movements.
Huh.
So I think there was some clinical application to it beyond just memorizing this chart. But yeah, it frequently came up. What was your experience?
Yeah, well, I mean, it was definitely, and I remember this as an intern being asked this, and this is like the truth that you have to recite, right? Like if you didn't know what was unstable and what was stable, then it was homework time, right? Like you had to go back, get out of the OR, go do some reading ahead of time. And it's 2025, right? I think some of this information, um, obviously how we practice now complicates it quite a bit in terms of stability info. But before heading down that path, understanding this info, which is the update on rigid fixation from wire fixation, as rigid fixation made things much more stable. But how they looked at stability was the amount of movement over a time period on the Ceph. And so they trace Cephs, and I'm sure everyone has read this, or if they haven't, I guess we'll talk about it a little bit. Um, but they trace Cephs at different time points to see how much the points moved forward, and they correlated it to the surgeries that were happening. And if it was less than 2 millimeters, it was seen as not relevant movement. 2 to 4 millimeters, I think, is uh, it is like, well, maybe it's significant, and then more than 4 millimeters was an unstable movement. I think that's the threshold. Let me read that as yeah, 4%, 4 millimeters is outside of orthodontic compensation, and that was determined to be clinically significant or highly significant. And then of that, using those thresholds, they looked at what percent of patients experienced those changes, both in the short term and long term. Short term was a year, and long term was 5 years. Again, this is two-dimensional Ceph imaging, right? And what's interesting is that the things that we think of as being stable or unstable, they aren't binary. It's a bit of a, some of those were stable. It's just the proportion of the group of patients, you had a higher proportion that changed more over that time period, depending on the movement. Does that make sense? Like
Not
higher
sure I follow it
percentage
here.
of patients, if the maxilla is moving down, relapsed more than 4 millimeters or more than 2 millimeters, depending on the category, than when the maxilla was moving up.
Got it.
That makes
Yeah.
sense. But it
Yep.
wasn't that everyone had that.
Right.
And it also did not relate to how far they were moving in the first place, which is kind of a crucial detail. I think the amount of movement plays a role in terms of the significance of change. And when it comes to relapse, obviously you don't want to have things change. But in two-dimensional world, what we're really looking at is AP and vertical. I think that's probably about as good as you can be. Um, when you that's your understanding of this, correct?
Correct. Yeah. I mean, you're limited by what resources you have at that time period, and I think that was one of their limitations.
For sure. And a lot of the things that we know in orthognathic surgery are from the 70s, 80s, 90s, and 2000s, right? Like a lot of the stuff that we know. And so, and there's great surgeons doing great surgery. It's just that, I think last week when we were talking to Dr. McCurry, some of the technology being explained as practice was in the 80s and 90s, it's hard for us to relate to now, right? And papers that were based off of that level of understanding should be considered in terms of how much of this is true, right? Because I think generally this chart is correct. Like, do you have any problem with any of these things? Like the most stable movement, maxilla up, lower jaw moving forward as long as the joints are fine, and then the chin moving.
Yeah, looking at this in isolation, as I think I was kind of mentioning to you before we hit the record button here, was the only thing I think I take a little bit of issue with, and maybe it's not even the right way of phrasing it, but I feel like correction of mandibular asymmetry is more stable. Like I think, rank that as a more stable movement than some of the things that are ranked more stable than it. And I guess it would depend, if you're just correcting asymmetry, then there's a component of mandible back, which I would say has some instability to it. So if you're looking at it through the lens of it, asymmetric correction has a component of mandible back. I could see maybe, but I feel like from a midline perspective, I don't feel like when I've corrected asymmetries and I see patients down the road, I don't feel like there's a tendency to return towards the asymmetric position. Maybe I'm doing something different, or maybe I'm wrong. But what about you? Do you, with regards to
Well, yeah. So
asymmetry?
I don't know. I try to when it comes to this info, in my mind at least, I kind of see it as like there's real stable stuff and really unstable stuff, and then there's the stuff in the middle,
Stuff in the
right?
middle, right?
And I
Yeah.
don't know. I think mandibular asymmetry is probably in the middle. I feel like that's probably right.
You think, let me ask you this way, do you think mandibular asymmetry is more or less stable than maxillary?
Um, yeah. So what I would point you to, so I mean, in this thing, so splitting up those boxes, you see how the boxes are like stacked on top of each other, and
Yeah,
it seems
yeah,
like well, look, maxilla asymmetry is higher than mandibular asymmetry. The
right.
data there, it's a little bit less, it's the proportion of patients, right? And so and again, it's two-dimensional evaluation of the asymmetry. And so evaluation of three-dimensional nature of the asymmetry might be a different animal, by the way. And I have to believe maxillas are a little bit more unstable than mandibles.
See, that's kind of what I would, the direction I would lean is I would almost flip, taking this at face value. And yes, I realize that I would almost flip mandibular asymmetry with maxillary asymmetry.
But I believe what they're referencing has to do with like AP asymmetry, like mandibles going back on one side and going forward on the other side.
Yeah, yeah, I guess.
Um, which anyway, I think when it comes to getting in the weeds, when it comes to the different movements, the on the very stable standpoint, they have maxilla up and mandible forward and chin in any direction. And these are categorized in the highly stable. And it was I think I was reading this right. It's 90% of the patients had either no change or mild change. I guess less than two or 2 to 4. Um, yeah, so the highly stable movements are that. Um, I mean, as an isolated procedure, maxilla up is stable, right? Like the things that cause instability or healing problems, like the mobility afterwards, change in the position of the bones in relation to each other from the time you see them at the surgery to where they are at the end of the case. Um, and then unstable orthodontic movements. But this from a bony side, the ortho is kind of put to side. So from a maxilla, they should have good bony contact. If that's the only dimension you're moving, if you're really just moving maxillary vertically, I can believe that.
Mhm.
Um, I think mandible forwards always like that asterisk always was like an interesting one because mandible forward, you're moving a sag with normal condyles 5-6 millimeters forward, or are we moving bilateral condylar resorption 15 millimeter advancement? I feel like those are different. I think
Well,
that
yeah.
that asterisk is an interesting one because that's pretty big in terms of like I would almost like you know there's part of me that thinks that like mandible back is more stable than unstable condyles mandible forward.
Oh, definitely.
Um, and so from the overall the short and normal face height, I think what they're getting at on the mandible forward is that it isn't a condylar resorption case. So again, getting in the weeds a little bit, but if the condyles are totally fine, mandible's moving forward, being stable, it does seem to be the case. I do believe most people tend to leave occlusions tight. Did you learn that on class twos, by the way?
What do you mean by occlusion tight exactly?
So when you're setting up a case for a planned surgery, you plan the mandible to be a little bit forward,
Yeah,
a little
like
heavy
over, you just
contact in the front,
mean, yeah, like you mean slide over correction essentially. Is that what you're
slide over
saying?
correction. Yeah.
Right. Yep.
Yeah. So with just mandible forward, shouldn't it be stable? Why would we do that?
Good question.
Um, I struggle on that one because I'm very much prone to do the things I was trained, and I try to, you know, rethink things somewhat. But The mandible forward, let's leave them tight because they'll drift back a little. It's not proven on here, right? Unless you're doing a two jaw. So I don't know if you really need to. I think mandible forward as the top box of being, extremely stable or highly stable. And then chin, because they have chin in any direction. And I don't know about that one either. Not to hate on this paper, because obviously at the time it was the best. Chin in any direction. There's some fancy chins and obviously cutting out revision from this whole case, but chin down. I don't know about chin down.
Yeah, I mean, do you think
Counterclockwise
they were looking
chin.
at, I can't remember the details to know if they even looked at chin down or if it was even mentioned in the
It was
paper.
all advancement chin.
Yeah, that's
Yeah,
what I
I
would have
think it was
thought
all
too.
just chin advancement. So, um,
I mean, I think we're talking sliding genioplasty anterior or posteriorly, right?
yeah, and I
We're
mean,
not
you can
talking
scroll through
down.
this as we're looking at it. But I remember seeing that it's really just chin advancement. Because they have in there
But
lower border osteotomy to reposition the chin. And so anyway, the from a very stable and then the very unstable mandible back. What do you think about that?
I mean, I would say that I tend to overcorrect those as well. I would think that that's a little less stable than mandible forward if we're talking about moderate movements. But I don't know that I would view that as all that unstable.
Yeah, so just the bottom category. So the problematic, I think it was problematic, or is it very problematic? The problematic, if you scroll through that a little bit, problematic, what that meant in its mandible setback, maxilla down, maxilla widen, is up to 50% of the patients have more than 2 millimeters change, and up to 20% have more than 4 millimeters change. Up to 20% have 4 millimeter change, which
Hmm.
um I know it's different for uh how we're moving things in terms of the magnitude, but that's not, I mean, it's unstable, but it's not like crazy unstable, right? Like you wouldn't anticipate
I
four
wouldn't anticipate
millimeter
four
change in everybody.
millimeters. No,
Like
because I mean, I wouldn't anticipate 4 millimeters with a 14 millimeter movement.
4 millimeters is a lot.
Yeah,
But so 1 in 5 patients moving 4 millimeters. Um, it is different than, everyone's moving that. So in this bottom category, which is problematic, which I believe to be the case, mandible back, admittedly, treatment planning, I feel like has changed than what it used to be in that now the consideration of pitch change and things like asymmetry and those bits, as well as the airway consideration tends to have less mandibles going back.
hmm,
Like I think the absolute mandible back movement is more rare. But I think the idea of that of setting the occlusions to overcorrection on a class 3 to where you leave them with a little bit of overjet, I practice that way, and
I do.
I'll be honest, I probably practice in a similar way for mandible forward or mandible back. What do you do?
Yep, same thing. I mean, I would say maybe a little bit more mandible back, but not drastically.
But let's say you take a 0.5 millimeter, so you do 2 clicks if you're quarter millimeter clicks in your treatment plan. So you go 0.5 millimeter in class 3 and a quarter millimeter in class 2. If you're reading
Yeah.
this paper, it's hard to defend that actually, right? Because you shouldn't change it for class 2, and class 3 you might want to go a little bit more even, right? Like, if half the people have more than a 2 millimeter change, I don't know. It's obviously hard because the flip side of that obviously is the other half don't have much change, and so
Right.
mandible back, I have the feeling like that's more stable, and so the stacking of the words being higher than like maxilla wider is important. Maxilla down, I think, is just like the worst. You know what I
Yeah.
mean? Like scroll down. I think maxilla down is way worse than maxilla wider. You think that's true or no?
You know, for me, the maxilla down, the volume of that is so much less than maxilla wider that I frequently, when I think about this, find myself going, well, like, I don't know that I have, I mean, like, I don't know that I have enough adequate volume consistently to get a good feel for it.
Scroll down to the maxilla wider because the middle part kind of gets messy, which is why I'm not trying to start with that. But
Is this
the
what you want to see?
yeah, the mandible back stuff. I don't know. I think our practices nowadays we just have less of that, but maxilla is wider. I feel like that's a pretty common thing. A lot of expansion kind of goals in orthodontics and surgery these days. Um, and then the maxilla coming down. I think the maxilla wider stability, like these are the charts. This is at the first and the second molar, or I'm sorry, the first molar and the first premolar. The percent of patients who had this much change. So half the patients of the first molar lost 3 millimeters of transverse, um, which is a fair bit, right? Um, and when it comes to the amount of movement, if you're only moving 4 or 5 millimeters and you lose half of it, I'll be honest, throughout residency, I perceived these numbers, and I swear I read this paper a couple times, and I the context I got is the percent of relapse. It wasn't the percent of patients who experienced an absolute of relapse.
Oh, I see
Did
what you mean.
did you always know it was that?
I think I did, but I mean, I think it's hard. It's a little bit difficult to interpret it that way. Like, I don't know how to say that, but I would also, the other point I would bring up with some of these things, especially the maxillary expansion, and I haven't read this paper. Yeah, I didn't do my homework as well enough. I haven't read it in a while, but frequently with the expansion of maxillas, there's attempted correction orthodontically in addition to what you're doing surgically. And I think that can add to the instability of what occurs, right? If you're measuring it from a dental position, like they're measuring molar to molar. Like if they have a 5 millimeter transverse discrepancy or after someone's tried to expand them to help them orthodontically, and they've got a huge curve of Wilson, things are flared out, you do segmental surgery and you get some orthodontic relapse in there too. That's not just surgical. Would you agree with that?
Yeah, for sure. Yeah, I mean that's one of the powers of this thing is it should be accounting for that somewhat, and that it was a single center, right? Like if they had the similar thing. If you scroll up, I think it's page 5, they talk about widening the maxilla and the like the standard discussion of SARPy versus segmental cut and that sort of thing. And just the generic um problems that you run into in terms of transverse stability in the maxilla. Um, I do think with time, these sort of things have gotten better. I do feel like palatal splants, I do feel like grafting, I feel like fixation is a bit better with these things. What I did want to put out there is, do you think patient printed hardware is going to impact these numbers in any way?
Ooh,
I know you don't like talking about that topic, but
you know
uh,
what gets me all
not to
riled up?
derail us from in the middle of the least stable movements on here. There's an update from wire fixation, which is the original paper, to rigid fixation. Does printing the hardware change this?
My initial reaction is if so, not much. Um, but I would be willing to say that's just my initial thought, and I am not basing that off of any fact. It should be, I mean, the fixation should be more rigid. I'll give it that. But at the same time, it's still, especially in the maxilla, it's still all buccally oriented from a transverse dimensional standpoint. Like you still have to account for other forces, other dimensions. Ah, man, and I feel like I fixate my mandibles pretty good. One or two screws and a plate a lot of the times. Like I don't know that patient-specific hardware for the mandible is much more rigid than what I provide. But in the maxilla, I could see that it's probably a little more rigid, but still only out on the external buccal labial aspect of the osteotomies. What are your thoughts on that?
Yeah, I mean, I think the low hanging fruit is maxilla down, right? Maxilla down, which is the
Yes.
one after this widening one. Maxilla down is just an unstable thing. Um, and they looked at 1 year stability and then 5 year stability. I'd be interested to see on the printed hardware if 5 year stability really plays out. But 1 year stability of the chandelier hanging down should be better when it comes to that sort of thing. Hardware can still fail at screws, so I think it most commonly fails there anyway. But from a first year change, I would expect that to impact it. I'm sure that's in process along the way, but
Hmm.
while we are in this unstable movements, I think the stable movements. I can't imagine it changes things much. Maybe some fancy chins now you can make a case for. And then two jaw surgery, the middle ground is some mix of what's happening, is how I perceive two jaw, by the way. But before we get in the middle, um, I feel like there's
So
probably an argument to be made on stability for
you think
patient
so
specific
you take
implants in certain situations.
you think it would be more stable?
For maxilla down, I think so.
Yeah.
Yeah, I mean, I feel like that's probably true.
Hmm.
If we're talking about the percentage of patients who experience absolute measurement of change, I feel like that's got to be on the plus column for patient-specific implants.
I would say if there's a movement that it would help with, it's that one. I would agree
Yeah.
with you there. But I mean, I don't know. I'm not as convinced that it's going to be a clinically or statistically significant difference between two options because I mean, there comes a point where you've reached a threshold, right? And going beyond that threshold doesn't have any value. So I mean, if it's adequately fixated, making it more rigid doesn't add to the construct at all. Again, I would say it is more rigid, but like if we're getting adequate fixation without using it, like do you need to like is increasing it? I mean, why don't we put three plate? Why don't we put three custom plates on it instead of one? I mean, like
Oh, sure. But
there's a
I mean,
threshold where it doesn't become there's no value in adding more rigidity or stability.
because I mean, fundamentally, what we're getting, what I get out of stability papers is things are unstable for different reasons, right? So maxilla is unstable when it's moving down because there are muscles of mastication and there are things that people do that they can't control, like grinding their teeth or clenching during the day, that can influence the postoperative stability, that it can change the upper jaw position while the upper jaw is healing. And if you scroll down, that's the maxilla down stability PowerPoint slide that was published in here. The decrease in overjet, right? So the as you know the this shows the percent of patients with change, right? The 2 to 4 and then greater than 4. But the occlusal changes that play out is as the maxilla goes up, then the mandible rotates forward, so their occlusion gets a little bit tighter. And so I would say that um, the hardware should help that out, especially in the early term. I generally worry about it ever not healing, right? Because the presentation of a non-union with load bearing fixation is a little bit different than with kind of more load sharing fixation. Um, and I do get concerned a little bit about, when you use semi-custom fixation and a maxilla coming down, uh, I feel like you spend more time getting good bone graft in there, like good rigid bone graft that's held in with positional screws. That's really like helping support the maxillary position. Whereas if you're thinking, oh, but this hardware is going to hold it, I'll just put some graft in and then get on with it. Um, I wonder that would be the little bit of hedge where I would say I'm not sure, right? So I feel like it's probably useful, but in that situation, but that's assuming the same grafting technique and everything. So um, anyway,
Yes, time will tell. Hopefully someone's studying that, but
yeah.
don't
So
know how accurate that'll be. All right. We
maxilla
derailed a
wide,
little bit
maxilla
there.
down, mandible back, unstable. Maxilla up, mandible forward, chin moving around, stable. And then you have in between, and in between is double jaw. It's all two jaw surgeries. And what's your take on that?
I don't know. Again, I probably should have done my homework and read this in a little better. I should have read it, period, more recently, but I don't know. I would feel like double jaw would make things well, I'm thinking in order of magnitude. So, instead of a 10 millimeter movement, I'm doing two 5 millimeter movements, and I would generally consider that to be more stable than a 10 millimeter movement when we're only considering an AP dimension here. And I guess that would be independent of what moves were being made. If you have two of the movements that are generally categorized as less stable, then I would expect there to be less stability. And if you're doing two of the movements that are generally favorable for stability, then I would expect it to be more favorable. What do you think?
Yeah, because I mean, I'm just what starts getting hard in two jaw surgery is I start wondering, are we just talking about patients that things are unstable in? You know what I mean? Like the people who need two jaw surgery, are we selecting for people who have worse bone? Does that make sense? Like, um, let's say, for two jaws, so maxilla up, mandible forward, right? So two solid movements, but the combination of the two, it's in this middle category of stability. I assume that has to do with counterclockwise rotation, so that the posterior maxilla has to move down. And so maybe not all the points in space are moving in that way. But I'm not entirely sure if that's the case because of the cephalometric limitation. And I couldn't figure that out from the paper either. Um, Also, I think there has to be people in two jaw surgery that are just moving more than people who have one jaw surgery, right? So like if you're moving, like you're doing upper and lower jaw surgery and Pagonion's moving 2 centimeters, and we compare that stability on a threshold of 2 millimeter to 4 millimeter relapse, and you're comparing it to a mandible forward that's moving forward four, you know what I mean? Like someone who moves forward 4 or 5 millimeters, a 2 millimeter relapse is a lot.
Right.
Where if you're moving 2 centimeters, 2 millimeters isn't all that much at all.
No.
And obviously you don't want 2 millimeters, but I can kind of chalk it up to healing and some condylar remodeling in that scenario pretty easily. Um, so what I'm getting at is I wonder if it's less the procedure and more what you're doing.
Yeah,
Does that make
exactly.
sense?
Hmm.
And I
There's
mean,
just a
it's
lot of
obviously
heterogeneity in
impossible to
there.
like parse that out, right? Like, I mean, the idea that two jaw surgery has more instability in terms of the percentage of patients that experience a significant change in bony points on two-dimensional cephs. I mean, I can buy that, right? And I can buy that
Right.
with mandible asymmetry. Um, the um, the reality of it now, though, is that treatment planning, we all plan in 3D world, right? And so when patients bring these things up or when people ask me questions about this, I find it hard to answer it because I honestly I don't know. Because to some degree, a lot of plans will be asymmetric. And let's say you're widening someone, you're doing counterclockwise rotation and you're advancing them 15 millimeters. You like advancing people like 6 millimeters, right? Like
Man,
you'd
I would
like,
love to have more of those cases for
yeah,
sure.
but 15 millimeter change, is it stable or not? And if you didn't widen the maxilla, is it more stable then? You know what I mean? Like
Yeah.
that kind of nuance is more like the clinical stability questions and trying to make the decision, like you were saying, like you trained and you learned about part of the decision making and treatment planning has to do with the stability concerns. I think just knowing the single jaw answers is good to keep in the back of your mind. Like, I don't know. I do think it's when I'm faced with a situation that seems to be unstable, trying to get more stable things in your column is nice. So maybe not widening the maxilla in that scenario. So, and if I think nowadays where I get concerned with is um, unstable movements with big magnitude, right? Like a greater than 10 millimeter transverse change in the maxilla, more than 10 degrees counterclockwise rotation of the occlusal plane, advancement of more than 10 millimeters in the maxilla. Maxilla forward stable, not stable, but I guess it's right below stable. But um, I can come up with some situations where that might not be true. So, uh,
Yeah, so that was, I mean, we've kind of touched on it here and there, but I guess to kind of maybe put a bow on this, like maybe summarize, or we can both try to summarize, like how do we take this knowledge and apply it to clinical practice in the modern day? So like we've talked about overcorrection a little bit. You talked about how you worry about certain combinations of movements are stable, but are there other ways that you implement this in your practice or how you approach things or your treatment planning or communication with the orthodontist? Does it come up in other ways other than just, hey, it's 2 weeks out from surgery and I've got to put together a plan and I'm going to consider this?
um, so I think the other part of this is what you mentioned at the beginning is that this is at a center that does a lot of orthognathic surgery, right? They're talking about surgery being done by surgeons. Obviously, residents are involved in this as well, and orthodontists who are used to doing this sort of thing. So this is likely as good as it gets. So that means it could be worse than this.
Oh yeah.
That makes sense. So I
Yep.
try to keep that in mind when it comes to this sort of thing, because it's like at the time, this is as good as information as they had being done by the people that were about as good at this as it could be done. And maybe there's minor differences, but if you're doing a handful of these things, it could be that you may run into a little bit more trouble with these sort of things. And so knowing the thresholds, and it's really like the stuff that's stable individually, like maxilla up stable, maxilla down unstable. And understanding that even if things are unstable, they can still heal in the plus minus decision in 3D planning of how to do it. So in my mind, it's like I'm comfortable, everything's going to be some degree of instability that I'm gonna have to manage, but I don't want to overweigh it. So this information gives me good kind of uh like additional info to know the nuance or try to make the right nuance decision. But I do think it's based off of a more experienced practice rather than initial practice. Because what do you think? An initial practice, if they did stability data in your first 100 jaw surgeries, I feel like a few of these would switch.
Yeah, maybe. I think there's a high likelihood of that. I mean, the other thing I would throw out is it is difficult to, as you were saying, with some of the nuance and other things here, is like it's hard to, or it's difficult to plan people to the wrong position. You know what I mean? Like overcorrection sometimes bothers me. Like you're looking at the bite and you go, the bite could be better. Like, why am I setting the bite here? The other thing I would say, even though it's the most unstable or one of the most unstable movements, like, are you going to plan the maxillary vertical position to a poor tooth show relationship because you're worried about instability? I mean, there's limits to how you can apply this information. Like, I mean, are you just going to say, well, that's an unstable movement. I'm not going to move the maxilla down 8 millimeters to give you appropriate tooth
Yeah,
show
I
and
mean,
smile aesthetics.
on that latter point, I mean, I think it isn't a binary thing, right? Like
Right.
it's I think what I learned when I review this, when I see this thing is it isn't that everyone has unstable movements. It's just that there's
Mhm.
a higher percentage of patients that are experiencing that. And obviously, no one wants any patient to experience that. But there's just the nature of where you're moving things down to, and the fact that we're working in humans that need to heal, or living things that need to heal. There can be it moving back to some degree. Um, and so I think there's that. I was gonna make another point with what you said prior to that, but I forgot.
About
Uh,
overcorrection and setting the occlusion to
oh,
where
the
it looks like.
overcorrection. Yeah. Because I
Mhm.
mean, the other part of overcorrection, and I don't know if we've ever talked about this or not, and maybe we've texted about it. I can't remember. But leaving things in a favorable position for the orthodontist is good,
Yeah.
right? So, orthodontist can manage a little bit of overjet in a class 3 situation. Like they don't hate that. Um, Leaving people too tight is not the best thing for most situations. Like leaving a class
Hmm.
2 to where they have a posterior open bite and they hit heavy on the anterior teeth is a hard thing for orthodontists to fix. They can only do so much IPR and retraction mechanics. And so I generally try to overcorrect, even though, we're all imperfect, in a way that'll leave it either right or at least an easy thing to correct, or relatively easy on the orthodontic side. And so, like that has less to do with the bony stability than it does
Right.
just the practical nature of it.
Yeah. And that becomes even more crucial in a lot of the surgery early or surgery first cases. You got
Because I
to really
mean,
kind of weigh those
leaving
things.
leaving the maxilla a little wide is fine. Ortho, I hear that from a bunch of different orthodontists.
Yeah, they would
Leaving the
handle that
maxilla a
easy.
little low is fine. Like I know that's not ortho, but leaving them a little long because people have different smiles. If you leave them a little short, there's a max with how much you can smile, right? And so there's different smiles and there's also aging. So fudging people down a little, fudging them a little wide, fudging them a little over jet. I think that's good planning. So I don't know, jaw surgery stability. It's it seems like it's settled. And then when I read this or when I talk to people about it, I realize it's like anything, right? Like it's maybe a little bit less settled than you might think. So um I know people are working on other projects and there's certainly updated stuff in different situations like counterclockwise rotation, MMAs and whatnot. But I thought this was cool. It is awesome that they did this, by the way.
Oh yeah,
This is pulling this sort of thing off is badass. They something like 14 or 1500 patients, I think, with 1 year follow-up. It's really great. So
that's tough to do.
while
That's
there's some
tough to
problems
do.
with it, it's also got great info that we can all practice a little better with.
Agreed. All right, you
So
want to wrap it up there?
yeah, I think so. I mean, it's kind of a different format today, so we'll see what people think of it. Um, maybe change it up, but we're back at it next week.
Yeah, hopefully, if you don't get
Or
too basted.
yeah, if you make it through the turkey. What time do you eat turkey dinner? Are you at
That's a good
dinner
question.
or do
I
you
think
do
it's more
like
of an
two?
afternoon thing typically.
You should
What
switch to
about you?
dinner. Like going to dinner is great. Like it's really nice to just have dinner.
Yeah, I
Growing up, I
agree. I
did
think
like the
when
2 o'clock.
when you do the midday thing, it's like the rest of your day, like you can't function a lot of
Yeah,
times.
you end up
Like,
eating like a late sandwich at like 8 o'clock and you feel terrible about yourself the next day. I mean, I probably do that anyway, but the evening dinner is nice.
yeah, I'm with you. I
So
again, when you're not heavily involved in the process, I find that, complaining and making suggestions or
yeah,
trying to make changes is probably not appropriate. Oh, you don't look a gift horse in the mouth, to throw in our old man saying uh, there in the middle at the end here as we wrap it up.
nice.
I kind of just go with it. If I was in charge and I was doing all the work, then I feel like I would probably have more to say about
Yeah.
some of the minutia. But when I'm getting food just handed to me on a plate, then I'm not gonna raise a fuss, you know.
Sweet.
All
All
right,
right,
cool.
man.
Well, that was another lackluster down fracture podcast, a podcast for talking jaws. Why are you so negative?
You're selling it short, man. That was a good episode. I like that one.
Down fracture podcast at gmail.com. Happy Thanksgiving or holidays to everyone out there. Um,
Happy
and we'll
Turkey
see
Day.
you back. We'll
See
see
you
you
next
back
week, man.
next week. All right,
All
see
right.
ya.